Good evening. Welcome to Conversations at the Carter Center. My name is Eve Bird, and I'm the director of the mental health program here at the Carter Center. We are thrilled to have the opportunity to collaborate with the Georgia Global Health Alliance and the Center for Victims of Torture to bring you this evening's conversation. The world is in the midst of a mental health revolution. There is rapidly growing understanding regarding the impact of mental health and substance abuse on the health and well-being of individuals, families, and our communities. We have significant knowledge regarding what treatment and supports are needed, and that early intervention does work. And we know that if we make a concerted effort amongst all of us, we will first and foremost improve the hope of 1 in 4 persons worldwide that too can lead a productive life. But we also, with this concerted effort, know that we will have a positive impact on the economies worldwide. Atlanta is playing a role in this mental health revolution. I hope that you too will consider how you individually and the organizations that you're affiliated will get involved. The time is now. I want to thank our panelists. First, Rose Scott, our facilitator this evening. She's an award-winning journalist and host of the midday noon program Closer Look, heard on Atlanta's NPR station 90.1 WABE. And then our expert panelist, Dr. Shekhar Saxena, professor of the practice of global mental health at the Department of Global Health and Population at Harvard. Dr. Janice Cooper, senior advisor, global mental health for the Carter Center. Dr. Paul Orney, senior clinical advisors for mental health at the Center for Victims of Torture. And Mr. James Sale, policy and advocacy manager for the United Global Mental Health, who joins us from England this evening. Let's see. Rose. Thank you all.
Well, good evening, and thank you all for being here tonight. I know the weather is a little challenging, but we are so appreciative of all of you being in this space. And yes, I am from the land of NPR and public radio, but y'all do not have to use your public radio voices. You don't have to whisper. Yeah. You have to be polite. But tonight's discussion, we're going to do more than just talk. It's more than just about dialogue. It's an exchange of ideas and maybe even some solutions to a global issue, mental health. And if you look at the definition by the World Health Organization, I'm going to read how they define mental health. Quote, a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. That is the definition of mental health. It may sound easy, but we all know it's not. And you think about the typical daily life stresses that we all have that can lead to some type of mental disorder. But then I want you to think about something else. I want you to think about someone living thousands of miles away, maybe someone who's in Syria or Kashmir or Yemen or the Central African Republic, or maybe think about the plight of the Rohingya people. And think about what their daily life stresses are. And think about your own. And then think about how mental health, how all that is impacted and how that leads to some type of mental health disorder. And so I am honored because I just get to ask questions to this wonderful panel who can talk about all of that. As we begin this dialogue, I do want to ask each of the panelists when they introduce themselves to just also kind of reflect on this, because this was something that I found very interesting. If mental disorders are on the rise in every country in the world and will cost the global economy $16 trillion by 2030, what does that say to you as experts in your area? What's working and maybe what's not? And Dr. Saxena, we'll start with you.
Thank you very much, Rose. Thanks, Carter Center, for doing excellent work on mental health and also organizing this conversation. In response to the challenge that has been posed by Eve earlier and by you, Rose, now, I'd like to make 3 points. The first point is that mental health should be looked at as mental health and not as mental diseases, which is what many people mean when they say mental health. We all have mental health, very good, sometimes very bad, and most of the time in between somewhere. So mental health has to be seen as a continuum, as a dimension, which is important for all of us. It's not that mental health is important for those 1 in 4 people who have a disorder. It's important for all of us. And we can do something about promoting our mental health, preventing a future mental disorder, and if we happen to have a mental disorder, we can get it treated and take help. So that is the concept which we need to start with when we look at mental health. And you quoted the definition of mental health by WHO, but if you go higher and quote the definition of health by WHO, it's about physical, mental, and social well-being. It's not about diseases. So that's where we should start. The second issue is about the burden that bad mental health or mental disorders pose to the society. We're talking about 800,000 people dying because of suicide every year. We're talking about 1/3 of all the disabilities because of any health condition because of mental disorders. And we are talking about, as you said, a huge amount of economic loss. It's not in millions, it's not in billions, it's trillions of dollars, trillions with a T. At least my head cannot get around so many zeros. We're talking about something which is just extraordinarily large. But let's translate it into the economies which we can more readily understand. We're talking about a community where there are people with mental disorders who are not being treated. It's such a waste of human resources, a human capital. We're talking about a factory, a business, where you will find a percentage of people who have depression, which could lead to absenteeism, but sometimes also presenteeism, which is responsible for 10% of the bottom line of that business. We're talking about schools where we do not give the best possible development potential to the children who will not achieve the human potential for their whole life. We're talking about these kind of burdens of all kinds, which are huge. But I want to also then refer to the fact that there is knowledge. We can do something about it. It's not a battle that is lost. It should not be lost because we have evidence-based interventions, programs, and I'll deal with it later on subsequently. But there's a lot one can do with the knowledge that we already have.
All right, thank you. Dr. Cooper.
Thank you. It's wonderful to be here. My perspective comes from somebody who had to flee Liberia during the Civil War and live in the United States for almost 19 years. And having been back in Liberia for 10 years, trying to contribute to the mental health supply. And in Liberia, when the Carter Center went in 2008, my former boss, Tom Borneman, to talk about how we might add mental health to the work that we were doing in access to justice, there was only one psychiatrist. Today, there are 3 psychiatrists, and 2 of them are non-Liberians. So one of the things that we as the Carter Center had to deal with is, what is the strategy? And we came up with a strategy that talked about supplying providers to address mental health issues, a strategy that looked at the huge stigma attached to mental health, and a strategy that really tried to focus on issues of justice. And our supply issue has led, 10 years later, I'm happy to say, to a cadre of over 300 mental health clinicians, over 600 nurses that are trained in WHO MHGAP, and 3 psychiatrists. And so and the Liberian government has also committed to sending people to be trained. But it's not all about the supply. It's also about...
I was sitting with clients in Minneapolis. I think the average time for each client was about 3 years. and many more than that time. And so in our services, we do provide a multidisciplinary care that includes psychologists, include nurses, includes social workers, and physiotherapists who can make it possible for the survivors to heal and claim back their lives. But then, if you put that in humanitarian context, for example, in Uganda alone, I don't have the exact numbers, but there's almost up to 1.5 million refugees right now. And if, say, 44% of those are torture survivors, and you want to provide work to bring some healing, those are just very huge numbers. So what we do, I think we've heeded the call to scale up. We've heard the term, scale up, so that some more people can get access. But at the same time, for us as CVT, we know what it takes to heal. It takes deep work. So how do you scale up, but then scale deep as well to bring real healing so that people can pick up the pieces of their shattered lives and get back to functioning?
Yeah. And we're going to talk more about that too in just a second, so hang with me.
Thank you.
Mr. Shah, I want to give you an opportunity to answer the questions. You look from your area expertise when you hear that number, that $16 trillion number.
Thank you very much, and thank you to the Carter Centre for such a warm welcome. It's a real pleasure to be here. I'd like to pick up on the 16 trillion. When I hear that, I just think, what a complete waste. And it's such a waste when I don't think there's any government budget in the world which isn't under pressure. And there's no economy there's very few that aren't striving at the moment, and that's a huge loss. I'd like to pick up on the financing aspect a bit more. So the recommendation is that low and middle income countries spend about 5%, or at least 5% of their health budget on mental health. And for high income countries, that should be more like 10%. But globally, the average spend or percentage of a health budget spent on mental health is less than 2%. And when you go to the poorest countries, the low income countries, it's less than 1%. Yeah. And not only is that a huge underinvestment in a particularly acute issue, it also demonstrates to me a lack of prioritisation from governments about the issue. Of the money that is spent through health budgets on mental health, it generally tends to be concentrated at the tertiary levels, that's institutions, when actually the vast majority of mental health conditions are mild and can be helped and supported through primary healthcare, through local clinics, through much more cost-effective and local to the person services. But sort of reflecting on the title of tonight's event and the sort of revolutionary aspect, I think we are closer than we have ever been to a tipping point, and I feel like it's just over the horizon. And I do remain very positive about the prioritisation of mental health, the adequate funding of mental health services. And when I think about that, I think too often the conversation drifts into, particularly in low-income and lower middle-income countries, the conversation immediately drifts into international finance and aid coming in. But the conversation has to be focused on domestic resources. We have to be talking about how countries sustainably fund good quality mental health services that reach everybody. Having said that, at United for Global Mental Health, we advocate for more spending from the international community to support countries to get up to a level where they can start to sustain it themselves. And we are starting to see that. We are starting to see existing physical health funds, such as, say, the Global Fund for the fight against HIV, TB, and malaria, starting to build mental health services into what they do, and so the funding's coming from there. And there are other examples of global funds that are doing that. So we are starting to see that, and so I do feel this tipping point is coming. Just the last point I'll make now is that also I think the other trap is that we think about mental health services only being provided through health systems, and we have to think beyond that. The new frontier, I think, and certainly we think this at United for Global Mental Health, is the workplace. That we can reach so many people through the workplace And not only are we then not losing that productivity, we're also just reaching people and improving their mental health. And we need to be thinking about other areas of government. Quite often the conversations are with the health minister, and actually do we need to have the conversation with the finance minister, or do we need to have the conversation with the education minister, and other places? And we are starting to see green shoots of new thinking about mental health, and I would look at New Zealand and Iceland with their newly proposed well-being budgets, which are cross-sectoral, and do look at the problem from a different angle. And I think if we can take that approach in more countries, that poor mental health is a complicated and holistic problem, and therefore we need a holistic solution to that.
Well, if we have this holistic approach to, I don't want to use the word solving, but if we have this holistic approach to execution, and Dr. Saxena, I want to ask you this because the question is, well, who takes the lead on this? Whether it's globally or whether it's here in the United States and with the World Health Organization, how they stepped up efforts to focus on mental health. From your viewpoint, you work in that space, what are they doing? What's working? And then what's not working?
Well, I think we all need to start thinking and start working, and many constituencies, many stakeholders are doing that now. So we are, as my colleague James was pointing out, we are near a tipping point. Let me give you just some examples. The United Nations Sustainable Development Goals, which is accepted by all countries at prime ministers and presidents levels in 2015, for the first time includes the phrase promoting mental health and well-being. So it's on the policy agenda. WHO worked for many years and has developed the Mental Health Action Plan, which is accepted by all ministers of health, including the Secretary of Health in US. So they have committed themselves for more action on mental health. But this is on the policy side. What about the health system side? We need to really integrate mental health within the overall health care, and that is at least slowly happening. If one has mental health problem, one should not be required to go to a specialist. One should be able to go to one's general practitioner. The doctor, you go for fever or for back pain, should be able to diagnose depression and treat it. And that's not happening, even in high-income countries like USA. 50% people with major depression in a country like USA are not identified and not treated.
50%.
50%. And in many low and middle income countries, that percentage is 80 to 90%, which is not being identified. That's why I keep saying, when it comes to mental health, all countries are developing countries. We cannot be proud of saying that we live in a developed country if you're talking about mental health. We all need to progress further, and one of the methods is to integrate mental health care within the overall health care. That's where you're going to reach many more people. So that's one of the solutions that one can think about.
Dr. Cooper, you mentioned stigma, and often when we talk about having conversations about something, you got to begin with having the conversation. And I know even in the Black community, when you talk about mental health and particularly Black men, talk to my brothers and uncles about mental health and they run out the door. That is an issue. That's a real thing. How do we begin to even have these conversations and get people past stigma, whether we're talking about here in the U.S. or somewhere around the world?
Well, one of the reasons why we are so interested in promoting mental health within the context of primary care is we have to normalize the ability to access mental health services. We have to normalize the need to reach out for help if you need it. Everybody should be asking how someone is feeling if you're a provider of care. And for us, we do work in schools, for example. So we have mental health services provided in public schools in Liberia. We have school-based clinics in some of the schools that includes both health and mental health. We work with religious and traditional leaders, mostly because we're concerned about the stigma. But as we work with them, we're also talking to them and telling them about how they can refer people for care.
Have we seen a change?
Oh, a sea change. We've seen a sea change. The leader of our mental health user organization in Liberia is himself a reverend. And many times he is the one that's in the forefront saying, I don't say that you give up your faith, But I say that you couple your faith with access to the evidence-based treatments that work. And so we need to have a holistic approach, and not one size is going to fit all. So for some youth, especially youth who are living in impoverished communities, many in ghettos, it will take one strategy. Those youth may not be in school, so it will take one strategy. For taxi drivers, it will take another strategy. Ebola was a big wake-up call for Liberia. Mainly because it really, at first, everybody was about infection control until they realized that Ebola, the fear-based behaviors, had to do with the mind. And then all of a sudden, as Dr. Saxena can tell you, PSS and mental health and psychosocial services became much more important and at the forefront. And that applies to any kind of disaster, whether it's an earthquake or a mass casualty accident. It can apply to lots of things. And so we need to make sure that we really walk the talk when we talk about no health without mental health.
Thank you. Dr. Orney, I want to go back to something that you said, because you talked about the refugees, and I want to make sure I had this number right. You said 44%. Was it you said about 44%?
Yes. Mm-hmm.
When you hear that there is such a large percentage of folks that need mental health, and you would think it would be a no-brainer that if someone is coming out of a situation where it's torture and trauma, that would be part of their resettlement, whether it's here in the United States or somewhere else. But what are you finding? What has been the barriers to why folks aren't getting that mental health treatment they need?
Yeah, so, and I'll talk both through our experience working internationally and domestically.
Okay.
There are lots of barriers, and stigma, if I may come back to this, is one huge one that you see, and just the attitudes towards mental health and the need to seek for healing and treatment. So in places where we work internationally, sometimes we have to start do that work from ground zero and educate people, do a lot of sensitization and work with what the culture says and things like that. But it's very surprising that usually once we have been on the ground for 6 months or over, we no longer seek a lot of people out. They know, they say, okay, go to CVT. But the stigmas are huge. And then the overwhelming needs, because once people start coming, for example, in Kenya, one of the camps where we work is in the northern Kenya. There's over 300,000 people. And given our funding, our resources, maybe even if we scale up, we could see maybe 500 a year. Then what do you do with the rest who still need work? But also with us, realization that if you do surface level, maybe just psychosocial support, torture and trauma needs healing because people have been broken at very deep levels. So if you have to stay with a client for maybe 3 months, how do you do that and yet also have them give space for others who need help? So it's something that we struggle with, and I think the global language is scaling deep as you scale up as well, and resources are threadbare, and we have to just work with those all over the world. But then, a place like in the Middle East, in Jordan, where we've been there for over 10 years, we worked a lot with the Iraqis, and then the Syrian crisis happened. And so it just keeps compounding. And one of the challenges you see is you have to take care of your providers, because the issue of secondary trauma and burnout is real. Many of our providers just come one day and say, I'm done. I can't hear one more story. And so that's, I think, a key thing. Our model is one that is supplemented by very close supervision as a way to keep people healthy as they're providing the work. So those are just a few things that I
So
can
you have
mention.
to keep the folks who are helping the other folks, you got to keep them healthy as
Yeah,
well.
yeah.
Mr. Sale, you're the numbers guy, so we don't talk about money. The solution to this is not just throwing money at it. You know, some will say, well, if you just had more resources, that means more money. But you talked about how much countries spend, whether they're high-end, affluent, or you know, low-end, how much they're spending on mental health. But is it, where does money fit into that? Is it, that's that simple? We just need more money to throw at the problem?
It's certainly the case that mental health is woefully underfunded. If you look at the disease burden, which I always feel is a bit of an odd phrase when it comes to mental health conditions, but depression is one of the leading causes of disability worldwide. And the strain it can put on health systems and society is enormous. The funding in no way matches that need. And so certainly money needs to be dramatically increased, but it also needs to be dramatically improved. So it isn't simply about the levels of funding increasing, it's about how we spend that. Now we can be much smarter about where we're spending it. We're gathering the evidence of where you get your best return, which interventions, which services will give you the best return, and that's growing all the time. And so we can be, with smaller amounts of funds, you have to be more strategic, and you have to make tough choices. I think if we had a world where we had adequate amounts of funding for mental health, I think we still have difficult decisions to make in terms of where we spend that, because you know, there can be a lot of waste and leakage in financing of health systems, and I'm sure we all know of sort of government projects which haven't worked, right? So it is certainly about identifying which are the best ways of spending it, and that's why I mentioned earlier about the workplace, about education systems, and about social protection systems, and basically cross-government and cross-public provision, that there's many ways that we can support people, and it's about identifying which of those work best in the context. We have to understand the population group that's being served, and also understanding where we're going to get the best return. Now, generally, sort of the average is for a return on investment on mental health services is about 1 to 4, but this can be increased. United for Global Mental Health, we recently supported an investment case for Lebanon and their mental health services, and we found that actually with the right types of interventions, that could be at 1 to 6. So you can have a much stronger return if you're picking the right services. And I think it's about, to get to that point, we really have to be listening to the experts of population groups and from experience. And too often politics can get in the way and make our decision making not always so good.
Well, you hit on that word politics, because I was about to get political, so whoever can answer this question. But is there a political commitment here? I mean, there's a debate tonight. I don't know if mental health will come up. Every time I watch debates, they keep saying the same thing, so I don't know if that's good. My little NPR personal comment. But is there, I'll stick with you, Mr. Sell, should there be a greater political commitment to this?
There already is. In international human rights, there is a right for everybody to attain the highest possible level of physical and mental health. And I think too often we say people have a right to health, and we immediately think physical health. And we don't really think about mental health. But it's there. It's enshrined in international law. We've already made that commitment. Now, do we need to reaffirm that commitment? Absolutely. Do we need to get more global leaders, more decision makers on the record saying that they are going to support mental health and improve the mental health of their citizens? Absolutely. The problem is with many political declarations is the accountability of that. We need to hold politicians' feet to the fire when it comes to mental health and the commitments that they make.
Dr. Saxena, let me ask you this, because we've talked about the government, but there's a role here in terms of civil society and businesses, and if we're having this holistic approach, what are some of the best practices when we talk about integrating the role of civil society and businesses in this fight for how we deal with mental health.
Before I answer that question, I would like to present another viewpoint to what James was saying. Yes, there is commitment, but we need to put money where our mouth is, and that is not happening. So it's okay for people to go and sign some kind of commitment, but are they really providing the investments that are needed from their budgets? And the answer is no. So I think we need much improvement on that. But yes, your question about what can civil society do, what can businesses do, a lot. Because we do know that the governments have their limits. And many times, civil society can actually step in to do what is necessary. It's not only for stigma removal and for education, they actually provide services. And that is something which is happening much more in low and middle income countries where the government services are particularly lacking, and civil society gets in and does the thing. What we still need to do much more is for businesses to get involved, because they are suffering losses which they don't realize in terms of increased productivity, in terms of treatment of people within their businesses who can be easily identified and treated. When I say easily, it's actually not easily, because there are many barriers that we have just now discussed. People don't want to disclose, people don't want to take help. But you can create an environment where people find it much easier to talk about their mental health and others and seek help where that is necessary. And the case for mental health within the workplace is extremely strong. We need more business leaders now to do two things. One, to look after mental health of their populations, that means in-house, but also in the communities that they serve, because businesses have a direct relationship with the communities that they are based in, and that's where they need to be more active in terms of increasing the investment in civil society and doing things which can be much easier done by them than by the government.
Dr. Cooper, I want to talk about, you mentioned earlier that first you had one mental health specialist for community, and then you had 3. But when you look at practices, someone say, well, that doesn't surprise me if we're talking about another part of the world. But even here in the United States, right here, just blocks away, there's someone who needs some type of mental health treatment and resources, and they don't know where to go. So are there practices that can be learned from here in the United States that's happening around the world, and vice versa?
Yeah, so I think I've worked in the United States too, so I know that there are whole counties where there are no child psychiatrists, for example. So it's in the wealthiest country in the world, you can get those shortages as well. And I think that when we think about particularly low and middle income countries where we've been focused on countries who've been through conflict or disasters, what you're looking for is how do you train up the workforce so that many people in the workforce can do some of the lower level tasks that are related to addressing mental illness. You still need psychiatrists, so I'm not going to say that because we don't have many psychiatrists in Liberia, we don't need them. We would love to have them. However, there's a lot that can be done with people with common mental health disorders, with people who are less trained.
We've just got a couple of minutes, and we're going to go to the audience for questions. But Dr. Orney, I want to get your thought when we talk about how do we get to a point where mental health is treated like any other, and I know Dr. Saxena didn't like the word disease, but that it is treated like any other physical condition, that it's not, compartmentalized in some other area, because your mental health affects your physical health.
Yeah, and I think that we as providers and also as organizations that do this need other channels, of course, civil society and all of the voice needs to come out there. But I think at CVT, one of our other components is that we have a kind of a research and program evaluation component, that because some of this, you need to use some of these numbers and results to do advocacy, because maybe that's the language that others understand. So sometimes maybe for me as a clinician, I just want to be kind of in the ditches doing the healing work. But you have to communicate that healing work to people who then can have influence at those levels.
Dr. Sell, let's talk about, or Mr. Sell, let's talk about campaigns and awareness. The reason I was going to put you on the spot because I read that you all were using some well-known people to get the word out about awareness and campaigns, even including the royal family. How's that working out? You don't have to address.
We scared them off.
But let's talk about awareness and getting
Excuse me.
people and the importance of when you have folks out there who are advocates for mental health and the effectiveness of that.
Yeah, absolutely. Well-known people, celebrities, are incredibly effective at reaching people, and I think I see it in two ways. So one, they have a public reach. The royal family in the UK have done a fantastic job over the last few years. You do feel a real difference, I think, in the country about the sort of normalisation of talking about mental health, which is fantastic. We also work with the Born This Way Foundation, Lady Gaga's foundation. Lady Gaga's done some fantastic work reaching out to people using her social media reach. And her mother, Cynthia, has been appointed as a Goodwill Ambassador to the World Health Organization for mental health. And these people have significant reach. And that second point about the WHO sort of leads me on to the second sort of target group that these types of influencers can reach. And that is the decision makers. Mm-hmm. If Lady Gaga phones Dr. Tedros, the Director General of WHO, he's going to pick up the phone and he's going to listen to what she has to say. Okay. Unfortunately, he doesn't want I ring in. But they also can draw the right people and people will listen to their messages. So next week or the week after, it's the World Economic Forum annual meeting in Davos. World leaders there, both from business and from governments as well. And last year we worked on a panel session that included Prince William and Jacinda Ardern, the New Zealand Prime Minister. And it was the hottest ticket in town. People wanted to be there. And the seats were filled with leaders of countries and leaders of industry, and they were listening to what was being said. So, yes, we do work with people who have very high profiles, and they're great at reaching everyone, and they're great at reaching specific people as well. And we find that that can have a real impact on the decision makers. The last thing, sort of just on the reaching everybody, and we experience this as an organisation. The more we use social media to talk about mental health, and the more we put it out there, the more actually we have to have a responsibility to look after those people that it reaches. You find, and celebrities, I'm sure, like Lady Gaga will find this as well, you get a lot of people reaching out to them who are reaching out to them because they can't access services locally. And sometimes it highlights just how little people do have in support around them because they're reaching out to, replying to tweets, bearing their soul, and in a very sort of serious and sometimes dangerous way. So it does highlight that there is a huge problem. And that's sort of the genesis of United for Global Mental Health. We're only a couple of years old, and it was established because anti-stigma campaigns, when they're successful, create referrals. And our motto is that everybody everywhere has somebody to turn to, and it's very much highlighted when those celebrities do put messages out. They get a response. People are asking them and telling them about serious issues, and it just highlights that not everybody does have someone to turn to.
As we wrap up this conversation, I want to focus on a group that we haven't talked about and their importance, and that is those who have lived this experience and the importance of involving them in this revolution, as it's been called. And Dr. Saxena, I'll start with you to reflect on the importance of having people who have lived this experience as it relates to mental health and being part of the solution.
I think that's an extremely important aspect. It should be nothing about them without them. When we talk about mental disorders, when we talk about mental health, we have to include them. And that's something which is not only conceptually correct, but practically very useful. because the kind of experience that they have had, they add so much value to policies, to services, to ways of dealing with mental health issues that professionals cannot think of. So professionals like me can only go that far. The next wave will be by people who have lived experience, whether because of their own mental illness or because of looking after somebody in their family. And that is something which provides a lot of quality, a lot of value to the efforts that are happening. But also, let's remember that these are also voters. So when they come out and say, we need something better, politicians do listen to that.
Yeah, thank you. Dr. Cooper?
I think you'll get a yay from everybody on the panel, actually. This is, it's really a red line in mental health. Nothing about us without us. You have to have persons with lived experience that are leading the way. And it is their experience. And they will also talk to you often about prevention and early intervention and what if in their lives. So I think it's critically important that persons with lived experience have a seat at all the tables that have to do with how you develop services, how you develop society. There are some societies that are much more open to persons with lived experience and predict. And I can talk to you about a community that is in Italy. It's called Trieste, where they have no hospitals for the mentally ill. They have 24-hour care. It's an experiment that's been going on for at least 30 years. And the commitment is not to have people feel as if they're in cages. The commitment is to have people feel as if they are part of the wider society. And so I think it's critically important for us to be able to, and now I have to say it costs Italy a lot of money, especially for those people who are mentally ill and also criminally involved or violent. But they take those steps. So in many places in Trieste you go, no matter what time of the day, there is mental health services available. 2 o'clock in the morning, there are places you can go to access care. But I think that it takes for us, back to nothing about us without us, to be concentrating and listening to those persons who lived experience and making sure that, and this does not mean pandering. This means having an honest conversation about their role in our society, in the society, and about what they contribute and how they can best contribute and best perform to the best of their abilities.
And speaking of a seat at the table, to also listen to
Absolutely.
folks. Dr. Orney, what about you? People with lived experiences?
So part of our model that we do internationally is really taking the people with the lived experiences, the people from the same refugee communities as our clients, and train them from the ground up to become counselors. And we have a model that we think we do a good, diligent job, that over a year or so, they themselves become competent counselors. I think our experience from Liberia, she could say that when we worked there, I think when people returned from war, they ended up forming like one of the first mental health organization, and they have a seat at the table on influencing Liberian mental health. And I think that's a model that we should try and make effort. It's not easy because it takes a lot, but I think that it's a commitment that we have to keep doing. The other thing, I think, beyond just people with lived experiences, our structures also should reflect things that then are familiar. For example, if you went to the refugee camp where we work, our healing structures are reflective of places, cultural places that are healing. And for me, that's part of the same discourse on lived experiences, so that people can feel the safety that's needed that can create healing. And we've tried to replicate that even back in the US. Of course, we wouldn't have the traditional structures, but if you came to Atlanta and saw our healing place here, it's a house. that we've transformed into a healing place. That's the same with Minnesota. So I think as much as possible to things that then can be replicated, like from community structures that bring the healing.
Mr. Seal?
Yeah, I mean, the first thing to say, and maybe Janice is too modest to say, but the Carter Centre's involvement of those with lived experience in Liberia is second to none, and they should receive a lot of credit for that, and it's a fantastic approach. I think for me it comes down to dignity. You know, I can't think of anything worse than losing your dignity in many ways. And I think if decisions are made on your behalf from those that don't really understand you, and those decisions are poor, I think you do lose dignity. And we talk a lot about quality and about rights in mental health and in the global health space as a whole, but for me, dignity is a real key. And I can't imagine how difficult it must be to cope with a mental health condition if you do lose your dignity and you don't feel like you are being listened to. I feel it must double down on the condition.
Absolutely. We're going to take some of your questions from the audience, and keep in mind, I know a lot of you may have a lot of questions. We want to be able to allow you that time and that space, but keep in mind, some of us have to go home and feed cats. It'll be me. So if you have I always work my cats in there. Talk about healing, let me tell you something, boy. You come home from being yelled at by a politician and you just talk to your cats and it all goes away. I've been yelled at by a lot of politicians. If y'all have questions, please, we invite you to come to, are they going to come to the microphones? Yes, so please, you can start making a line and have at it. And we'll start over here. Yes.
Yes, can you hear me?
Yes.
Thank you so much to all of you for serving on this panel. Any thoughts on the use of telehealth, telemedicine for mental health delivery? I know that there's a live health online, physical health, and recently there's been launched for mental health. Any thoughts on the power of using technology to take expertise from one area of the globe and share it elsewhere?
Very important. Technological advances are really making the task much easier, and they can be used in a variety of ways. One of them is people seeking help directly through telecommunication media, and so the therapist can be elsewhere. In fact, now there are AI-based programs which can actually do some of the groundwork before you reach a person. Although I must say that personal contacts are absolutely essential for treatment. But the other one, which is also quite important, is to increase capacity using training remotely. We have less number of providers, but we have also less number of trainers. So the training can be imparted remotely, and that can actually work very well. Just to also say, there are now psychotherapy programs which can be delivered online. And that really expands the scope of how many people you can serve without really getting out of our office. So that's all is extremely important. There are also chat lines, there are other ways. So all of that is really expanding a lot. And very interestingly, the mobile penetration in some of the low and middle income countries are reached so high that actually they are jumping ahead even beyond some of the high-income countries. And that's one of the innovations that is extremely useful.
You want to add anything?
Yeah, I would say, yes, I think telehealth, especially from my area where it's mostly about building the capacity of providers, that having providers be able to, from one culture or country to another, that have more expertise to work with providers, both in terms of training, but also in terms of supervision, can be very helpful. I have to say that there's some parts of my country where the internet is not that good for you to do telehealth, so that would be the other thing. And I think the other caveat would be to bear in mind the cultural differences. We have persons who have lived experience in Liberia that will see something that is going on in, say, Atlanta, for example, with users, and think that they can do that in Liberia, and it's sometimes detrimental to their health. So I think that we have to just recognize the situations and the settings when we think about that.
I'll come back over here.
I love that we're talking about remote care and mental health tonight, and I know that a lot of the mental health burden, both in the U.S. and globally, is based in rural areas. And I also know that most of the resources that are allocated for mental health are not allocated to rural areas. So can you guys speak about possibly any strategies or programs you're aware of that have been successfully implemented in rural parts of the world?
So I think with rural, would that also include in refugee camps? Yeah, so basically for CVT, a lot of our work are in refugee camps, and there are also partners that do similar work in same conditions. But we also do a lot of work with returnees or communities that have been affected. Some of our work is in northern Uganda, where there was a long history of war, and we work with rural communities out there. So most of it, we do our best to tailor it to fit the needs of the communities and the culture. But as you could tell from some of our discussions, the needs are overwhelming, and you have to work around stigma, and you have to work around creating safety and stabilization. An example, in northern Uganda, we would go to villages, and it's very rich. There's a lot of rainfall, the soil is rich, and people do subsistence agriculture. But people would just sit and not go to do what they needed to do. And as a result of this kind of just a widespread trauma that they had gone through. So we had to reach people where they are. We have our healing centers right in the villages. We found religious leaders who, some of them had even changed churches because they were so overwhelmed by every church day. People would just come and say, please, can you help me? So very overwhelming needs, but I think slowly and slowly in those communities, we found ways to do the work, but the needs are a lot.
And there are examples in the United States, too. Washington State, New Mexico, there are lots of places where they're online, doing telehealth online, mental health online, as well as training, so that there are lots of examples in rural parts of the United States where this is going on.
And
Probably
also,
not enough money, but...
And also in other countries, Australia is a very good example where telemedicine, telepsychiatry, telemental health is very active, but also in some of the middle-income countries like Mongolia, which is a huge country with low resources. They're using simply a kind of chat line to organize, to supervise, to train very effectively. So yeah, there is a lot of scope there.
Also in India, there's a program called the Atmiyata program, and they're using that type of technology for training community health workers. It's a really good program. It's worth looking up.
And I'll just say, and I don't know if anyone is here from Mercer University, but Mercer right here in Georgia, they're doing a lot to help rural communities, particularly when it comes to health and wellness by using telemedicine. So anyone from Mercer, you can tell them that Rose Scott said.
And I can remember as far back as maybe 15 years ago when we had very few psychiatric resources that were linguistically competent for rural Latino populations. And we were by phone, literally by phone with a psychiatrist in rural Minnesota. There would be a Latino psychiatrist talking to a local psychiatrist to access care for those people.
Thank you. Good question. Next.
Great. Thank you guys so much for being here. Dr. Saxena and Mr. Sale, you talked about the corporate world being kind of the new frontier for mental health. And my question is largely to do with the measurement of different metrics. So measuring education, advocacy versus measuring treatment. And in the corporate world, I feel that a large part of the reason that that's the new frontier is because it's measurable. You can measure the reduction in insurance premiums. You can measure to a certain degree productivity through mental health. What are the ways in which we are measuring proactive activities like education, like early intervention, things like that, that are a little bit less tangible, that make an argument for that being equally as important as the treatment, the reactive treatment?
Good question.
I think you have raised another very important point. If we don't measure, we don't change things. So it's very important to measure correctly, accurately, reliably over a period of time, which allows for comparison. When I was working for the World Health Organization, we started 20 years back publishing what we call the Mental Health Atlas, which was the first time that resources and policies and programs were at least being recorded and compared across countries. We have had 5 editions of Atlas, but we are going beyond that now. As you correctly point out, it's not only the number of psychiatrists, number of psychologists, and the policy. It's about the larger environment. What the population like? What is the education level? What is the demographic pattern? How many people are poor? How many people are refugees? And we have started actually since last year to start another project called Countdown Mental Health 2030, which is in keeping with the Sustainable Development Goals. And we have a much larger set of indicators that we're using. It's not all easy because sometimes data are just not available, but we're trying our best to accumulate all indicators and then aggregate them and show to the world how badly they are treating mental health, which is very effective.
Thank you. All right, try to get all your questions in, sir.
Good evening. My name is William Beverly Blanco. I am a person with lived experience. I am a peer. I am one of those that works with their brothers and sisters to scale up while you can dive deep. And it warms the cockles of my heart to hear you talk about peers and persons with lived experience as part of the solution to the grave need that we have. So I thank you, and I hope to work with you.
Thank you.
Appreciate your efforts
Thank you for sharing.
very much.
Come back over here.
So you all spoke about integrating mental health care into businesses, into schools, and I'm curious to hear about what some good effective ways of integrating mental health care into schools are, and how you either persuade or enable schools to integrate mental health care so they can teach new generations how to better take care of their mental health. Thank you.
So I can talk about what we've been doing in Liberia, which is a multifaceted approach. So we are training, I'll start with the top level and come down. So we're training science teachers in neuroscience. Most of those science teachers never got neuroscience when they were being trained. And we're training them so that they can integrate it into their science curriculum. So kids start learning about the brain very early and how the brain functions, etc. So people start knowing about that. We're training teachers in WHO School Health Manual, where every teacher knows about the different types of social, emotional, and behavioral disorders that children may manifest in their classroom and how to deal with them. Why is that important in a country like Liberia, where we have a lot of stigma, where children with mental illness or with social emotional disorders or behavioral disorders are seen as being ignorant or stupid or bad? Is because the teachers then recognize, no, the way to deal with these children is not to throw them out of the classroom, but to adapt the classroom so that all can learn. And for many of these teachers, it's their first time. They learn about their own self and their own brain in the process. And so these are some of the ways. It's not just about providing services in schools, but it's about creating the culture within the schools. Those of you who know that a child may not have social emotional behavioral disorder, but they get into school and they start being bullied, and then all of a sudden they do start having emotional problems. So those are some of the ways we're dealing.
Hi, thank you all for being here. My name is Will. I'm in the mental health program as an intern here at the Carter Center, and I was just curious, since I've heard the theme of stigma come up multiple times tonight, what tools or what methods are successful or effective in implementing some destigmatization practices, specifically in underserved populations, like whether it's the African American male population that it's really hard to provide mental health services, or maybe with postpartum depression and mothers around the world, what works in not just working around stigma, but really at a systematic level changing stigma.
I'll speak maybe to our work more specifically. So at CVT, as we work with torture and trauma, we this is all about everything we do, because torture itself by design is really meant to create shame, stigma. So that awareness comes in our work from how we design all of our work. So I think the best way to say it is that we think about this at structural levels, but also in terms of processes. To give you just an example, at structural levels is how do you even just locate your healing place? And this is coming from our understanding that in the healing process, and part of the destigmatization in general, there has to be safety and stabilization as at the onset before you even move on to the next stages of healing. And safety is all wrapped up in a process of destigmatization. In some of the places in refugee camps, we even locate our centers maybe close to a hospital, where then it would look like people are going to hospital, then they slide into a CVT center. Back in the US, we locate our healing centers, it's just a house. So but also, I think in terms of process, just even a mention, because people also come in with so much distrust. Even, can you imagine trying to run group therapy? So sometimes we talk about confidentiality, but doing this work, you won't just talk about confidentiality once at the beginning of treatment. It becomes like this process. In session 3 or 4, you notice things that you still see as a lot of people are mistrusting and fear. Then you talk again about confidentiality. So it's so integrated in so many aspects of the work, and it's something that you have to think about. Even how you create logistics. In Nairobi, we do a lot of work with LGBTI clients. And how do you reach them? Because then if they move around the city, they're very ostracized and a lot of homophobia. So how do you make services that can make minimal? We run services at a church, and we make sure they are there on days that the other activities are not there just because of the homophobia. So just a few things to mention, but there's a lot more that we think through as we work with clients.
So we really think about, what do you think about the word stigma, stigmata, something that's a stain on you? And what we do is work with training both providers and recipients of services on what is stigma, what does it feel like to be stigmatized, right? What are some of the words that we use to have somebody be an other, stigma, and what are some of the things they can take as a person with lived experience and address both the self-stigma as well as working outwards. So, and we do a lot of training on stigma. We train religious leaders on stigma. We train police officers on stigma, because one of the things that happens is that if there is some issue or problem that happens with a person with lived experience, and then people will start saying, oh, that person has mental illness. And the immediate thing is to use force. So we were very fortunate to be exposed to crisis intervention training from Georgia. So a team from Georgia went to Liberia to train police officers in how to intervene with people with mental illness in a way that's safe and in a way that's non-stigmatizing. And increasingly, because when policemen come now, they first say, is this a CIT officer? And then they're the ones that intervene. They talk to because usually a crowd will gather around, and the crowd is all out of control. And so they control the crowd. They talk about the fact that the mental illness is not contagious, because it's one of the things that people are really concerned about. And they do like a mini anti-stigma section. So it's really important that you train every sector. We started training our immigration officers as well, because the same thing comes up oftentimes when people cross the border. So you train as much of your society as possible, and at the same time, you're training persons with lived experience about self-stigma and about how they can be in the community and also contribute to having a stigma-free environment. But it takes work. It takes a lot of work, and it takes each one of us that's part of the community catching ourselves when we exhibit stigmatizing behaviors.
Thank you.
Thank you for being here tonight. My name is Rochelle H.C. Hirsch. I've been working with personal transformation for over 30 years. Transformation meaning not that you are aware of something, but indeed that your instinctive reaction patterns shift. For example, in someone who's had a near-death experience, after that, one of the common elements is they no longer fear death. What I'm wondering about, my eldest niece actually is a peer counselor up in Virginia who trained here in Georgia to begin with on their program. So my question to you in doing therapy with people is, what are you finding are the better treatment approaches, whether it's EMDR or EFT or whatever it takes to help not only reduce the stress a person is experiencing, but to help them move forward in a self-empowered way? What are the best treatments that you're finding? And we also know, of course, it's the therapist, him or herself, that often makes the breakthrough with a client, just the trust that's developed.
I also have my colleagues here, like Dr. Andrea Northwood and Dr. Adobe, if they want to say something, because they've done this work longer than me. But one of the things that I could say, rather than talk about a treatment like a specific one, at CVT we've tended to take more like a basic approach, just knowing what has happened to the survivors, and that whatever the approach, that the first phase of treatment has to be that of safety and stabilization, because you create that and then you can go ahead. And then the second phase is where you then really work with the client through trauma processing. And then because trauma disconnects people from themselves, from their families, from their communities, from their hopes, then in the last phases you do a lot of reconnection work. So that people can reconnect with themselves, people can reconnect with their families, people can reconnect with their communities, people can reconnect with their future, so they have hope again. So, but several modalities can work through these phases, and I think that has tended to be our approach. But my colleagues can add something to that if they feel so.
We've not done much with EMDR. We've trained, we've actually used EMDR in one cohort of our clinicians that were particularly themselves traumatized. I think for our setting, it's particularly sophisticated. But we do the range of psychological interventions like interpersonal therapy, cognitive behavioral therapies. They're trained in all of those modalities.
Thank you very much.
Apologies, they gave me the wrap up. I really apologize. Did you have a quick question or comment?
Just a very short question.
Okay, short question?
Keep it short.
Go ahead.
First, let me thank all of you. I have been providing mental health services to large organizations for many years now, and hearing what you're doing is really uplifting. Thank you for all of your work. We have reduced the stigma to bring people to mental health services through companies by simply crunching the numbers and showing them what a cost savings it is. It's good business to have mentally healthy employees. It saves a lot of money. So now, hardly a week goes by at my organization where we get many incoming calls of people in 48 states requesting mental health services. Some of those people just come right out and say, look, I just had a relapse on my 20 years of sobriety. I'm having suicidal thoughts. So we take that information and we reach out to find therapists around the country. And my question to you is, how do we attract more people to the mental health field because we have a shortage of mental health providers? What can we do to... Thank you.
Pay them what they're worth.
Yeah.
That's very good.
I want
Thank
to
you.
bring up Mary Ann Peters now from the Carter Center.
Evening, everybody. First, help me thank this incredible panel and Rose for her wonderful, wonderful work. The discussion was not only lively, but I think it was hopeful, and I give all of you great credit for allowing us to leave this evening with hope in our hearts, in spite of having begun by learning just how huge the problem is. Many thanks to those of you in the audience who braved the rain tonight, and to our online viewers. And please remember that the webcast will be archived on cartercenter.org for future reference. I hope you'll join us for the next conversation event in this series, which will be held on February 27th. On that day, we'll host a discussion called Tunisia, the Best Hope of the Arab Spring. So please come and hear why Tunisia is the only country where the Arab Spring may be said to have worked, what challenges Tunisia still faces, and what the Carter Center is doing there to bolster democracy and human rights. So thank you once again.